mode.
Hi everyone, welcome to the webinar on HIV drug therapy in 2019. My name is Alexandria Wilson. I'm a faculty member here at St. Louis College of Pharmacy with a practice site at Washington University Infectious Disease Clinic. Thanks for joining me this afternoon. Throughout this presentation, if anyone has questions, feel free to type them in the chat dropdown and I will answer them at the end of the presentation. Additionally, in about an hour, you should be receiving an email that contains instructions on how to obtain CE credit for this presentation. I have no conflicts of interest to disclose to you. And my one learning objective for this presentation is for you to be able to compare and contrast the current options we have for the treatment of HIV. We're going to start with a case. The patient is a 25-year-old male who presents to his PCP with complaints of headache and increased sinus pressure, as well as some fatigue. He's not seen a physician in years, and today he's requesting an HIV test. He has no comorbidities, he takes omeprazole as needed, and he has no known drug allergies. His sexual history reveals that he uses condoms 90% of the time, his vitals are normal, and his physical exam is normal. A set of labs are ordered, which includes a CMP, a CBC, an FLP, an HbA1c, and a TSH, as well as that HIV test that the patient is requesting. And a couple of medications are prescribed. Those include loratadine with pseudoephedrine and fluticasone nasal spray. Within the next couple of days, the patient's symptoms have resolved and he has no complaints. And his lab tests come back, which are within normal limits, except for that HIV-1 test that he had asked be performed, which is positive. At this point, an HIV-1 RNA or a viral load is ordered, and the result is pending, and the patient is referred to the infectious disease clinic. At the clinic, we have some more lab results available. The HIV-1 RNA results at 360,000, a CD4 count results at 401, and an HIV genotype is performed. And this is the drug testing for resistance that is done on the HIV virus, and that shows resistance to Efavirenz. Some additional STI tests are performed, which are negative, and his hepatitis serologies show that he is not co-infected with hepatitis B or C, which might factor into what we choose to use to treat the HIV virus. Before we decide what we are going to use to treat this patient's virus, let's talk about how we approach treating in general. So the first thing I want to talk about is who gets treated with medications for the HIV virus. And this has historically been based on a patient's CD4 count up until several years ago, at which point the guidelines recommended that all patients, regardless of CD4 count, all patients who are diagnosed with the HIV virus be started on treatment. There's also been some recent studies looking at when patients should be started on treatment. In other words, how quickly they should be started on treatment following their diagnosis. There have been a couple of studies in countries outside of the United States that have looked at starting patients on treatment the same day that they are diagnosed with the virus. There has also been one small pilot study done in the United States looking at this same thing. At this point, because of the resources necessary and other things that should be performed, we in the United States have not fully embraced same-day treatment. More likely what is done is that patients are started on medications as quickly as possible. At my clinic, it's about 4 to 6 weeks after their initial visit. After having been referred to the ID clinic. So we can gather all the labs and all of the necessary information and establish a relationship with the patient. And then finally, the reason why we're all here is to learn about what we should use to treat patients. Well, there's a lot of things that need to be considered as we try to select what's best for a patient. So this is my own personal list of things that should be considered. You might have additional things to add to the list. The first thing is going to be drug resistance. So does the virus have any resistance to medications? And those medications, of course, then should not be used. We also need to think about potential ADRs related to the meds that we might be using. We need to be aware of the patient's medical conditions and any other medications that they might be taking, because we will definitely need to assess for drug-drug interaction potential, which can be a huge thing with our antiretrovirals. We need to think about pill burden and how frequently medications need to be taken, and whether or not they need to be taken with food or on an empty stomach. All of those things potentially can impact adherence, which is vital for controlling this virus. And then, of course, we have treatment guidelines. The treatment guidelines not only take into consideration all of the studies that have been done with the different medications, but all of these additional factors that I just went through on this slide. So to give you just a visual of how important things like pill burden and frequency of administration and whether or not meds need to be taken with food, I thought I might just give you a couple of pictures. This first picture that you're looking at right now is an example of an older regimen that we might have used to treat the virus, probably like mid to late 90s. So this is a combination of saquinavir, stavudine, and lamivudine. And what you see are the number of pills that would need to be taken for this particular regimen, as well as how often the medications would need to be taken. So this was a 3 times a day regimen, and every single time the medication needed to be taken with food. So as you might imagine, it could be pretty difficult for somebody to take this particular regimen, and this is definitely not a regimen that we would ever think about using anymore. And this second picture is one of a newer regimen. This is our first single tablet regimen that contained 3 medications inside of the same pill. And this is Efavirenz, tenofovir, disoproxil, fumarate, and emtricitabine. This particular fixed dose combination became available in 2006. And it was just 1 pill once a day. It didn't need to be taken on an empty stomach. Since this first single tablet regimen became available, we now have about 7 additional single tablet regimens. So while I have this labeled as a newer regimen, there are some drawbacks to its use, and it's our first single tablet regimen, but the subsequent single tablet regimens have become available have some advantages over the use of this one. So even this one that became available in 2006 is not used very often any longer. We'll talk a little bit more about why in just a little bit. So let's talk about how medications have changed over the years, medications for treating HIV. So of course we have an increased number of options. So today we have about 30 different antiretrovirals that we might choose from to treat this virus. We also have a lot more medications that have become available in combined formulation. So I talked on the previous slide about our first single tablet regimen. So that's 3 medicines inside 1 pill. We also have a lot of fixed dose combinations that contain 2 medications inside of 1 pill. So looking for ways to try to make it easier for patients to take their medications is always very important. Our medications over the years have increased in potency. We have been able to reduce pill burden, reduce the number of times that patients take medications. These days, we're always looking to have patients take medication just once a day if we can. Sometimes we have to do it twice a day, but we should never have to do it 3 times a day. We've also had some food restrictions, so medications that need to be taken on an empty stomach or medications that need to be taken with food to maximize absorption. We've had a general reduction in those restrictions over time. And finally, our newer medications are much safer. So over the years, the medications that have been developed have a decreased potential for ADRs. So we talked a little bit about how medications and treatment have changed over time. Let's jump to where we are right now and talk about the medications that are being used in practice today, starting with what the guidelines tell us to do. So these next few slides are taken from the DHHS Guidelines, and that's the Department of Health and Human Services. These are the guidelines for the treatment of the virus that we follow here in the United States. Probably some of you know that there are other guidelines for the treatment of the HIV virus, and I would say for the most part, they're all consistent with one another, but what we follow here in the US are the DHHS guidelines. And the last time that the guidelines were updated was in October of 2018. So we're first going to focus on what these guidelines recommend for treatment-naive patients, so never having been on any treatment for the virus before, and specifically talking about what is recommended for most people. So the guidelines have a few different tiers, but the tier recommended for most contains the most highly recommended combinations. Again, they call that for most people. So we are still using 3 active medications to treat the virus, and we are basing these regimens, we call them, off of one of 3 different classes. So those 3 classes that we are choosing to base our regimens off of are our INSTIs, which are integrase strand transferase inhibitors. We call those integrase inhibitors for short, our protease inhibitors, and our non-nucleoside reverse transcriptase inhibitors. So you have 3 choices, but of those 3 choices, the only choice that is recommended in this recommended for most category are the integrase inhibitors. In other words, we should be trying to base our regimens off of integrase inhibitors, not protease inhibitors, and not non-nucleoside reverse transcriptase inhibitors if we can. The guidelines called out specific integrase inhibitors that are included in this category. And there are 3 of the 4 available included. So those are Bictegravir, dolutegravir, and raltegravir. And the order in which they're listed is simply alphabetical. They are considered equivalent in how highly they are recommended. Now again, we use a combination of 3 active medications to treat the virus. So we would choose one of these 3 integrase inhibitors and combine that with what we call a 2-nuc backbone or a 2-NRTI backbone. And we'll talk about backbone in just a little bit, but let's first continue to talk about our integrase inhibitors. So why is it that the integrase inhibitors are the only class that's left in this recommended for most category? What happened to the protease inhibitors and what happened to the non-nukes? So this next slide shows you just a general way to compare these 3 different classes of medications. And so what you see on this slide, looking at your integrase inhibitors down here, integrase inhibitors as a whole have less potential adverse reactions associated with them, definitely compared to protease inhibitors, and compared to non-nucleoside reverse transcriptase inhibitors as well. When we think about drug-drug interactions and pill burden and barriers to resistance, well, those are going to be a little bit variable depending upon which specific integrase inhibitor you are talking about within the class, and that's why they are in italics underneath this integrase inhibitor section. So, for example, drug interactions, I would say, are relatively less with our integrase inhibitor class compared to our protease inhibitors and compared to our non-nukes, with one exception. And that one exception is with integrase inhibitor Abacavir, which is always boosted with cobicistat. That definitely has a high potential for interactions, but the other 3 integrase inhibitors do not. What about pill burden? So in general, pill burden is going to be less with our integrase inhibitors than our protease inhibitors, and less than our non-nucleoside reverse transcriptase inhibitors, with one exception, and that one exception is raltegravir. Raltegravir is an integrase inhibitor that is taken once or twice a day, depending upon which formulation you are using. And raltegravir also has an additional drawback to its use, in that it is the only integrase inhibitor that is not currently contained in some fixed-dosed combination product. The other 3 integrase inhibitors are available in some fixed product. And then finally, barrier to resistance. So we have a total of 4 integrase inhibitors. Our oldest integrase inhibitors, which include raltegravir and elvitegravir, have generally a low barrier to resistance, but dolutegravir and bictegravir, the 2 newer integrase inhibitors, have a very high barrier to the development of resistance. And so, to summarize, integrase inhibitors as a class have less side effects, could have less drug-drug interactions, lower pill burden, and depending upon which one is selected, a higher barrier to resistance compared to the non-nukes and compared to the protease inhibitors. And those are some of the reasons why the integrase inhibitors are the only class that remains in that highest recommended for most category in the treatment guidelines. So for those of you who don't see these medications too often, I mentioned one called Bictegravir. This is our newest integrase inhibitor. It's been out for a little bit over a year at this point. So I just wanted to dedicate one slide to it with a little bit more information. So Bictegravir has been compared and found to be non-inferior to dolutegravir. It's a once-a-day integrase inhibitor, extremely well tolerated with very few drug-drug interactions, has very high potency and has a very high barrier to the development of resistance. One drawback to its use, at least at this point, is that it is not available as an independent medication. It is only available in a co-formulated tablet that contains, obviously, the Bictegravir, as well as tenofovir, alafenamide, and emtricitabine. So if you're going to use it, you have to use those other medications as well. What about how these specific integrase inhibitors compare and contrast to one another? So from a side effect standpoint, things that are similar with all four of the integrase inhibitors, while there are some very rare reports of insomnia and depression in the literature that includes suicidal ideation as well as attempts, and these are very rare reports. At this point, at least at my practice, this is not a reason to avoid using any of the medications within this class in someone who has, depression or some other psychiatric illness, but it's definitely something to be aware of, and should something develop once starting an integrase inhibitor, that it needs to be addressed. But at this point, it is in rare numbers reported in the literature. What about differences that exist from a safety standpoint? Well, raltegravir has been associated with increased CK as well as myositis and rhabdomyolysis. And then cobicistat-boosted alvategravir has some nausea and diarrhea associated with it, as well as the potential to increase lipids. From a drug-drug interaction standpoint, things that are similar with all of the integrase inhibitors is that they are bound by polyvalent cations. So they can be bound by calcium, iron, and their absorption can be prevented. And so we manage that by spacing the administration of these cations apart from the time that the integrase inhibitor is taken. Things that are different, well, I already mentioned that as a class, integrase inhibitors have a lower potential for drug-drug interactions with one exception, and that exception is the cobicistat-boosted alvategravir. And as you might imagine, because it is boosted, it does have a high potential, but the remainder of the integrase inhibitors have a very low potential for drug-drug interactions. I've already talked about how the resistance barrier is different between the four integrase inhibitors. And I already mentioned some drawbacks to the use of raltegravir from an administration standpoint, being that it's either dosed once or twice a day, depending upon the formulation that's being used, and the fact that there is no co-formulated product that contains raltegravir. And then finally, one other thing to mention is that there are no food restrictions or requirements with any of these integrase inhibitors, except with alvategravir, which should be taken with food to maximize absorption. Okay, going back to our slide that tells us what the treatment guidelines say about what medications and regimens are recommended for most. We talked about our integrase inhibitors and how we would choose to base our regimen off of one of those three. Let's talk about our 2-nuke backbone now. So the 1,2-nuke backbone that is recommended over and over again in the treatment guidelines is tenofovir with emtricitabine. And now tenofovir has an asterisk next to it, and that's because there are two different formulations of tenofovir. The older formulation is tenofovir disoproxil fumarate, and the newer formulation is tenofovir alafenamide, and they differ in a side effect potential. There is one other 2-nuke backbone that is recommended, and only when it's used in combination with integrase inhibitor dolutegravir. So that's the final bullet on this slide. So when dolutegravir is used, the alternative to nuke backbone is abacavir and lamivudine. Okay, so let's talk about these nukes just a little bit more. So I mentioned about the two formulations of tenofovir that are available and how they differ in terms of side effects. So as you might guess, the older formulation, which again is the disoproxil fumarate, has a higher potential for side effects compared to the newer formulation, which again is the tenofovir alafenamide. So what side effects am I talking about? I am talking about nephrotoxicity and bone loss, osteopenia, as well as osteoporosis. So why is that? Well, both of these tenofovir formulations are prodrugs of tenofovir, but they differ in where they are converted to active drug. So with our old tenofovir disoproxil fumarate, it is converted to active drug in the plasma, but the newer tenofovir alafenamide is not converted to active drug until it's taken up within the cell. And so the exposure to the active drug tenofovir is much less when alafenamide is used compared to when disoproxil fumarate is used. And that, in fact, is the reason for the lower side effect profile. What about abacavir? So I mentioned abacavir might be considered if the integrase inhibitor dolutegravir is being used. So the two things that I would want you to know about abacavir, the first is that it has a potential for a systemic hypersensitivity reaction. And so because of that, we do some testing prior to using this medication. The testing that's performed is the HLA-B5701 allele testing. If that allele is present, then the patient is at higher risk for having this particular reaction to abacavir, which means that abacavir must be avoided at all times. And then finally, at this point, there is a still controversial association with an increased risk of MIs when abacavir is used. Again, this is very controversial, and we hope to know more. At some point. Emtricitabine and lamivudine are the other two nukes, NRTIs, that you saw mentioned on the slide taken from the guidelines. I don't have any separate slides on them here. Honestly, they are extremely well tolerated, very easy to take, have almost no drug-drug interactions, and so almost always, as long as they can be included as part of a treatment regimen, then they are included. The one problem that comes up sometimes is when the virus has resistance to those two medications, and then of course they are not going to be active against the HIV. Okay, so we are going to move on from that most highly recommended regimens, again that's recommended for most, to the second most highly recommended regimens. And the guidelines call that recommended for certain or recommended for some patients. Okay, so there is an integrase inhibitor class recommendation here, and here's where we see that fourth integrase inhibitor show up. So that fourth one being cobicistat boosted alvategravir is included in this recommended for some or certain category, and then raltegravir is repeated with a different backbone, different than the tenofovir that we talked about previously. We also see our protease inhibitors and our non-nukes included in this recommended for certain category. So specifically with our protease inhibitors, it's darunavir or atazanavir. They must both be boosted, and your booster could be either cobicistat or ritonavir. With our non-nucleoside reverse transcriptase inhibitor class, we see rilpivirine, and that's only if the baseline viral load is below 100,000 and the baseline CD4 count is over 200, because what's been found in studies is that if the viral load is higher than that or the CD4 count is lower than that, then patients might not respond as well, and there might be more failures and more resistance developing as a result. Also in our non-nuke category, we have Efavirenz, and then our newest one that has become FDA approved, Doravirine. Let's first talk about the 2 protease inhibitors that are included in this recommended for certain or some category. So I did a side-by-side comparison of those 2, darunavir and atazanavir, and there are a lot of similarities. So all of the bullets that are in black are the things that are similar between these 2 protease inhibitors. So they both can be dosed once a day. They both need to be taken with food. They both have a low pill burden, and they're both co-formulated with the booster cobicistat. They both should always be boosted, and as a result of that, they have a pretty high potential for drug-drug interactions. Compared to the other protease inhibitors, so the other medications within this class, they have less metabolic toxicities and less GI intolerances associated with them. And so what are some differences between them? So the differences are the bullets in purple. So one good thing about darunavir is that it is available as part of a single tablet regimen. So again, that's 1 pill once a day for treating the virus, while atazanavir is not. Atazanavir has 2 additional potential drawbacks to its use. The first is that it has a potential to cause hyperbilirubinemia and jaundice in a patient, which can happen in up to 30% of patients, and the degree can be a little bit different. But when you are educating a patient about this potential ADR, I have found personally that a lot of times they don't even want to risk the development of it. And then finally, another drawback to the use of atazanavir is that it requires an acidic environment for absorption. So when patients are taking proton pump inhibitors or H2 blockers or even antacids, there is either some spacing or some of those medications might altogether need to be avoided rather than run the risk of decreasing the absorption of this protease inhibitor. What about with our non-nuke medications? So first I did a side-by-side comparison of the 2 older non-nukes, Efavirenz and rilpivirine, that are included in the treatment guidelines. So things that are different about them. So Efavirenz needs to be taken on an empty stomach, while rilpivirine needs to be taken with meals. Specifically, prescribing information recommends a minimum of 400 calories to maximize absorption. Efavirenz has relatively more drug interactions than rilpivirine is going to have. However, rilpivirine, like atazanavir, needs an acidic environment for maximal absorption. And so again, you run into problems with some of those medications that are being taken for things like heartburn. What about side effects? So Efavirenz, as probably everyone knows, has a pretty high potential for neuropsychiatric side effects. So anything from very vivid dreams, which happens in up to 50% of patients who start on Efavirenz, to the other end of the other extreme of things like hallucinations and suicidal ideation. It also has a potential to increase lipids. Rilpivirine does have some reports of depressive disorders associated with it, but the incidence is much, much lower than that of Efavirenz. It's also considered very lipid friendly. At doses above the 25 milligram dose that we use for the treatment of the virus, there has been some prolongation of the QTC. So for patients who have maybe other medications or other risk factors already on board that could cause this same QTC prolongation potential, that might be a concern. And then finally, both are available in a single tablet regimen, so fixed dose combination, again, 1 pill once a day. And rilpivirine in particular, one of the fixed dose combinations that is available with it is considered an alternative for women who are pregnant. And then finally, Doravirine gets its own slide because this is our newest antiretroviral to become available. This was FDA approved back in August, and it's been looked at in both It's been looked at in naive patients, but compared and found to be non-inferior to ritonavir boosted darunavir as well as Efavirenz-based regimens. It's dosed once a day, regardless of whether or not the patient eats with it, so food does not matter. And it is available as a single tablet regimen. The one thing to know about the single tablet regimen is that it contains that old tenofovir disoproxil fumarate, the one with the higher risk of nephrotoxicity and higher risk of bone loss compared to the newer formulation. Other things to know about Doravirine that are not on this slide, but its absorption is in no way impacted by an acidic environment, so it is not going to have those issues with the PPIs or the H2RAs. And at least at this point, there are no notable ADRs associated with it. Now it is a newer drug, so maybe we'll learn a little bit more as we increase our experience with it, but there's nothing notable to point out to you at this time. Okay. So again, reminding you that the treatment guidelines for HIV for a naive patient always say to start with 3 active medications to form your regimen. The guidelines do address 2 active drug regimens, and this is something that has been coming up in the literature a little bit more frequently recently. It was also discussed at the CROI conference a couple of months ago. So let's talk about what the guidelines say about using just 2 active medications for treating this virus. So the guidelines say if a patient cannot take Abacavir and cannot take tenofovir, then this might be something to consider. The regimens that have been looked at in naive patients and have been found to work include Bictegravir with lamivudine, ritonavir boosted darunavir with lamivudine, and then again ritonavir boosted darunavir with Bictegravir. Now this one is twice a day and really should only be considered if patients have a baseline viral load below 100,000 and a CD4 count over 200. So there's a few different options, but again, this is something that the guidelines say you could consider this if your patient cannot take Abacavir, cannot take tenofovir. Some of you out there might know about the fixed dose combination of rilpivirine and Bictegravir that has been FDA approved somewhat recently for treating experienced patients who have already achieved viral suppression, so they already have an undetectable virus, and we're looking to simplify their regimen. That is not a medication that we look to use in naive patients. So that is someone who might be experienced, who has already achieved suppression for at least 6 months. We might simplify down to that. But that is not the same as something that we might use for someone who's never been on medications at all. Okay, so we're finally returning back to our patient, and my question for you is, what is the most appropriate medication to use in combination with a 2-nuke backbone of tenofovir alafenamide, so the newer tenofovir, and emtricitabine? If you remember back to the patient, he was newly diagnosed with HIV, a young person. His CD4 count was 401. His viral load was 360,000. His virus was resistant to Efavirenz. He had no comorbidities. He was taking loratadine and pseudoephedrine and fluticasone nasal spray and omeprazole as needed. So you can answer this question on your own. Do you think that the most appropriate medication is going to be A, rilpivirine, B, ritonavir boosted atazanavir, C, cobicistat boosted elvitegravir, or D, Bictegravir? If you said letter D, Bictegravir, I agree with you, and here is why. So other choices, rilpivirine and atazanavir. Remember that those medications both require an acidic environment to maximize absorption, and this patient was taking omeprazole as needed. And while you might be able to space that out with atazanavir, you couldn't space it out with rilpivirine. And you'd also have to do some education on how to space it out and hope that your patient remembers to space it when he starts having GERD symptoms and wants to take his omeprazole. So those two medications, for that reason, might not be the best choices. We also have some drug interactions with atazanavir, which is a protease inhibitor, and cobicistat-boosted Abacavir. So the interaction is with the fluticasone nasal spray, which is not something that you might expect because very little of it is systemically absorbed. But enough of it is absorbed and enough of it is inhibited. Its metabolism is inhibited by the use of these boosting drugs, so the boosters being ritonavir and cobicistat. And so when a patient takes these boosters and uses fluticasone, either the nasal spray or the inhaled formulation, that puts the patient at risk for Cushing's syndrome. And so for those reasons, or for that reason, those two choices might not be the best. We also have a concern with rilpivirine in the patient's baseline viral load being well over 100,000. Remember that in the studies, when the patients were stratified based on their viral load and their CD4 count at baseline, those that had the viral loads over 100,000 did not perform as well. So that might be a concern in this patient whose viral load is 360,000. And other things to think about. So Bictegravir is available as a single tablet regimen, and that would make it easy as we could possibly make it for the patient to take the medications. And it also is available with tenofovir alafenamide, which is that newer formulation of tenofovir with better bone and kidney health. And so, in fact, let's say that this patient is prescribed Bictegravir as a fixed dose medication with tenofovir alafenamide and emtricitabine, and the partner is appropriately referred for pre-exposure prophylaxis, which is PrEP, and that's a whole nother talk that we're not going to get into here. But then things happen, and the patient is lost to follow-up, finally comes back about a year later with a cough and shortness of breath, diagnosed with pneumocystis pneumonia, so PCP or PJP. And what he tells you about his medication for the virus is that he was stretching it out by taking it every other day, then he ran completely out, and then he decided that he would share a friend's cobicistat-boosted Abacavir, tenofovir alafenamide, and emtricitabine. And you call his pharmacy to get the refill history on his medication, which is contained there on the slide, and certainly that shows that there's a lot of non-adherence going on. So you get some new blood work, and you see you have a CD4 count currently at 40 with a viral load of just under 590,000. And you also do an HIV genotype, which shows resistance to lamivudine, emtricitabine, raltegravir, and elbacavir, and a CMP that's within normal limits. So a question for you to answer in your heads, is it appropriate to restart Bictegravir, tenofovir alafenamide, and emtricitabine? Remember, that's what we started the patient on the last time we had seen him. Is it appropriate to go ahead and restart that? And hopefully your answer is no, absolutely not. That is inappropriate. And that's because the patient's virus has developed resistance to the emtricitabine portion of the regimen. So non-adherence is the #1 way that resistance develops, and this patient, remember, was spacing out his medication and then was sharing a friend's medication, and that is probably the reason why the virus has developed some resistance, not only to emtricitabine, but to some other medications. And if we were to use or just restart what he had been on before, that would mean that we were restarting just a 2-drug regimen, which at this point, again, is not recommended by the treatment guidelines. So the emphasis here is that when your patient has been non-adherent with medication, it's important to order that HIV genotype test and follow up on those results so that when you are designing a new regimen for a patient, you don't choose a medication that's not going to have activity against the virus. And then finally, I'd like to end with one big takeaway message here, and this is just a true-false question. So key takeaway HIV drug therapy in 2019 is relatively easier to take and has a lower risk of toxicity compared to HIV drug therapy used in early years. Is that a true statement or is that a false statement? And hopefully you didn't take too long to answer that one. It's absolutely a true statement. Our medications have become much better. They're much easier to take. They're safer. So we've made some major improvements here. And with that, I'm going to go ahead and end it. I don't see any questions, but I'm going to give you a few minutes. For those of you that do have some, remember that you can go to the chat drop down and type in your questions, and I'd be happy to answer them. If you don't have any questions, then I thank you for joining me today.